let us start with Sure Shot 250 medicine topics. These topics are very important. You have to know everything about them. So let us start. The first topic in the endocrine system, which I want to cover at the start only, is the various tests that we do in order to diagnose the various conditions. So for the Cushing's syndrome, we do the low dose dexamethasone suppression test, and that is the investigation of choice. High dose dexamethasone suppression is done for the differentiation between ectopic and pituitary adenoma. Addison's disease, co-syntropin or ACTH stimulation test is the diagnosis of choice. For the pheochromocytoma, 24-hour urinary fractionated metanephrenes are the confirmatory. Okay, and special test, clonidine suppression test, but that is not done routinely, that is done sometimes only. For hyperaldosteronism, we have salt loading test, which is obsolete now, so we do saline infusion. For diabetes insipidus, we have water deprivation test. Okay, for SIADS, that is syndrome of inappropriate ADH secretion, we have investigation of choice, which is water loading test. For acromegaly, the screening test is IGF, okay, insulin-like growth factors, whereas glucose challenge test is the confirmatory test. Okay, otherwise if they ask you what is the screening test for this, then the screening test is IGF, insulin-like growth factor test. Understood? So these were the IOCs and they should be on your tips. Now starting with the first topic, which is diabetes mellitus. Okay, now in diabetes mellitus, you all should know that there are 3 classical symptoms. Okay, 4 are there, but polyuria, polydipsia, polyphagia and weight loss. So these 3 classical symptoms plus the random blood sugar if more than equal to 200 milligram per deciliter, then we say it is diabetes. So what are the symptoms? Polyuria, polydipsia, polyphagia and weight loss. Right, now out of these, polyphagia cannot be measured. Okay, next is fasting blood sugar. If it is more than 126 milligram per deciliter on 2 consecutive readings, then the diagnosis can be established. Glucose tolerance test is a 2-hour glucose tolerance test. We give 75 gram of glucose to a patient and then we check after 2 hours. If it is more than 200 milligrams per deciliter, then the diagnosis of diabetes mellitus can be made. Okay. Next is HbA1c. HbA1c, dear students, is very important. It is number 1, an independent criteria for diabetes mellitus, and secondly, determines long-term diabetic control. Okay, next is what is HbA1c? In this, the glucose is non-enzymatically attached to form glycated hemoglobin. Normal is 5.6, more than equal to 6.5% is diabetes mellitus. If somebody is already a diabetic, then good control is less than 7, poor control is more than 7. Okay, so HbA1c is very important. Normal, glycated hemoglobin. What does HbA1c tell us? It tells us about the glucose control over 2 to 3 months time. Right, because the half-life 3 to 4, you should say 3 to 4 months time, because of RBCs is 120 days. Clear everyone? So it is very important. Now this chart is very important, dear students. This chart has to be known. Right, for a normal person, fasting blood sugar is 70 to 100. Right, after 2 hours of glucose intake, that is after the glucose tolerance test, it should be less than 140 milligrams per deciliter, and HbA1c is 5.6% normal. For a patient who is having diabetes mellitus, the fasting blood sugar is more than equal to 126 milligram per deciliter. That after 2 hours of glucose tolerance test, it is more than equal to 200 milligrams per deciliter, and HbA1c is more than equal to 6.5%. For impaired glucose tolerance, it is between these two. So I always tell my students to learn the two sides, the normal and the diabetes mellitus and impaired glucose tolerance. You can answer yourself. So if I tell you a patient has fasting blood sugar level as 124. After taking 75 grams of glucose, after 2 hours his sugar is 180 and his HbA1c is 6. Then tell me, in which category will you put the patient? Normal, impaired glucose tolerance, or diabetes mellitus? Next is this magic chart. Okay, in this beta you have to know the difference between type 1 and type 2. Type 1 and type 2, you have to know the difference. Type 1 is also known as insulin dependent diabetes mellitus. Type 2 is known as non-insulin dependent diabetes mellitus. The type 1 diabetes results from any antibodies which are formed against the beta cells. Type 2 is occurring because of insulin resistance. Right, family history is not significant in type 1, it is significant in type 2. Obviously, type 1 occurs early in life, type 2 occurs later in life. Right, type 1 normally the person is thin, type 2 the person is obese. Then complications, ketoacidosis, diabetic ketoacidosis is more common in type 1, whereas in type 2 diabetic ketoacidosis does happen, but non-ketotic hyperosmolar coma, that is more common. Right, next in this type 1, what happens? Often we have ketonuria, we see blood insulin is decreased, whereas in type 2 insulin level may be normal but there is insulin resistance. Right, pathology we all know it is atrophy or beta cell death. Right, whereas in type 2 it is the depletion is occurring, resistance is occurring. In type 1, we see insulin and C-peptide ratio to be low, whereas in type 2, because resistance has developed, we might see insulin and C-peptide are very high. Treatment for both of them is nutrition and exercise, plus for type 1 is always insulin, whereas for type 2, you have to remember oral hypoglycemic agency. First is always nutrition and diet therapy. That is the first thing we give to the patient. Then we give oral hypoglycemics. Then if they are not able to work, we give insulin. Next, this question is very important, everyone. HLA association is with type 1 insulin dependent diabetes mellitus, whereas no HLA, no antibodies are seen in type 2 diabetes mellitus. HLA DR3, DR4, DQ2, very important. Okay, next in this chart we have to do MODY, the maturity onset diabetes of young. See, this also occurs in the young people. Next, what is most important in this is the vertical transmission. That means from the grandfather to the father to the son. You know, if all the generations are having diabetes mellitus, then it is MODY, you should know. Right, it is also non-insulin dependent. Here also beta cell dysfunction occurs, but insulin resistance is not there. Obesity may be there, may not be there. Right, the fasting C-peptide and insulin levels here are also low. The sulfonylureas, you can write here, sulfonylureas can be the treatment for the MODY. Okay. Done, beta. This can come. Okay, the difference can come between type 1, type 2 and MODY. You should know. Next is the complications in diabetes mellitus. For the complications, you should know the complications can be vascular, non-vascular. Non-vascular being cataract, infections, repeated infections, especially which infection is very common in diabetics, candida, right, and the genitourinary problems may occur. In the vascular, you have to know there are microvascular and macrovascular problems. Microvascular are diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, whereas macro, big vessels, are peripheral arterial disease. Here we call it PAD and CAD, right? MI, strokes, right, cerebrovascular accidents, right. How do you control the microvascular? It is only by strict glycemic control, right. If there is strict glycemic control, microvascular will be occurring a little late in life. Macrovascular, you can prevent macrovascular if you have strict glycemic control, correct, but if BP is maintained. Okay, so if a person has BP and he has diabetes mellitus, he is very prone for a stroke, heart attack. Let's start with diabetic retinopathy. We should know it is microvascular, small vessel pathy. Okay, and diabetic nephropathy and neuropathy, they occur almost at the same time. Chances are very high. And if there is a person who has been diagnosed type 1 diabetes mellitus, and there is a person who has been diagnosed type 2 diabetes mellitus right now. So who will you send for immediate eye checkup? That is the type 2 person, because we don't know from how many years he was having diabetes mellitus, right? Major indicator is the duration and age of onset and glycemic control. Strict glycemic control is very important to control the microvascular pathies. Okay, next types, we have proliferative and we have non-proliferative type of diabetic retinopathy. The first thing to occur is microaneurysm. If there is a diabetic eye, we see blot and dot hemorrhages, we see snowflake cataract. So these are the catch points, right? We see macular edema. Eventually blindness may occur. Treatment is pan-retinal photocoagulation or bevacizumab. Right, so please know. Now this is the diagram, everyone, which you may see. One is the diabetic eye. This is proliferative. Proliferative means new blood vessels are becoming more and more in number. Non-proliferative means you see aneurysm, microaneurysm, you see blot and dot hemorrhages, right? You see Okay, this is hypertensive eye, where you see splinter or flame hemorrhages, right? Splinter or flame hemorrhages. Please remember these two diagrams. For diabetes mellitus, dot or blot hemorrhages are important. Snowflake cataract is important. Hypertensive eye, we see flame, splinter hemorrhages. Next is diabetic nephropathy. The first thing to occur is increased GFR. This is very important. This is the first sign to occur in diabetic nephropathy. First clinical sign is microalbuminuria, and this is the most reliable early marker for diabetic nephropathy. What is microalbuminuria? When you have 30 to 300 milligram per day of albumin in urine, right? Next, macroalbuminuria means it is the next step when the albumin excretion exceeds more than 300 milligram per day. It can also be prevented by good glycemic control, plus in later stages we may give protein restriction. Diabetic nephropathy, please remember what are the drugs that prevent the diabetic nephropathy. They are ACE inhibitors. Okay. Next, everyone, let us come to the various lesions that we see in diabetes nephropathy. The first one is diffuse glomerulosclerosis. The second one is nodular. Please remember, diffuse is the most common, whereas nodular is the most pathognomonic. Okay, most characteristic. Nodular glomerulosclerosis is also known as Kimmel-Steele-Wilson lesion. So two questions come. What is the most common nephropathy lesion that we see? Diffuse glomerulosclerosis. What is most pathognomonic? Nodular. Okay, next they ask you what happens thickening of glomerular basement membrane occurs, right? Capsular drop, fibrin caps, they are certain terms which may be used for lesions of the diabetic nephropathy. You all should know. Now, if you see the above diagram, everyone, this is Kimmel-Steele-Wilson lesion. They are a white or nodular deposit of hyaline matrix, and they are most pathognomonic. Okay, so please remember two very important questions. Okay, next is diabetic neuropathy. Diabetic neuropathy involves both myelinated and non-myelinated nerves. It is irreversible. It is irreversible because even the myelinated have been affected. First sensation lost, everyone, is sensory, then motor, then autonomic. The first sensation to be lost is vibration sense. So sensory is lost first. In sensory, the most common is distal symmetric polyneuropathy, right? Distal symmetric means both sides, both legs equally will be affected. You have pins and needle sensations. You have paresthesias which are distal symmetric, both the legs. Okay. Next treatment, we give pregabalin or duloxetine. And also there is occurring pain in legs at night, which is known as restless leg syndrome. Restless leg syndrome occurs in diabetes mellitus and it occurs in IDA. Done. Next, autonomic. Autonomic occurs last, matlab it is the least one to occur, but if it occurs, it leads to tachycardia, postural hypotension, erectile dysfunction, urine retention, diarrhea more than constipation. This question has also come. What occurs in diabetes mellitus? Diarrhea, silent MI, and third and sixth cranial nerves are involved, but a pupillary sparing occurs. So please remember diarrhea, silent MI, tachycardia, urine retention, postural hypotension. Diabetic neuropathy, first sensory loss occurs. Okay, if you see this particular diagram, you should know we have distal symmetric. Okay, then mononeuropathies may also occur, motor neuropathies may also occur, but they are very less and they occur later than the sensory. Okay, next is diabetic dermatopathy. Now, diabetic skin problems, please remember most common is the diabetic foot, non-healing ulcer in the foot. Others can be acanthosis nigricans, that is blackening of the skin, right? Dupuytren contracture. Now, acanthosis nigricans, everyone, darkening of the armpits, darkening of the neck, occurs in diabetes mellitus and pancreatic cancer. Dupuytren contracture is when the finger which is farthest from the thumb, the ligament of that finger is thickened. Then necrobiosis lipoidica can occur and lipodystrophies can occur. Okay, next, please see these diagrams, everyone. This is what? Acanthosis nigricans. This is what? Dupuytren contracture. And this is your diabetic foot. Now, next question which always can be asked is, what are the 3 life-threatening problems which may occur in uncontrolled diabetes? They are rhinocerebral mucormycosis, you all know. Amphotericin B is the drug of choice. Next is emphysematous pyelonephritis and malignant otitis externa. So if you get a black rhinocerebral photo, blackish discoloration is occurring, and they give you in the question that a patient is diabetic, it is mucormycosis. If they give you a picture of the ear and it is having pus, then it is malignant otitis externa if history of diabetes mellitus is there. Okay,